Please welcome the Director of Health Equity Initiatives at NCQA, Dr. Brian Buckley.
Good morning, everyone. How's everyone doing? Good? Good morning? There we go. Well, as they mentioned, my name is Dr. Brian Buckley, he, him pronouns, and I'm the Director of Health Equity Initiatives for NCQA. For the folks that didn't hear my intro yesterday, I support NCQA's enterprise strategy across the organization. And our mission is to improve the quality of healthcare. And I know if you heard yesterday's panel, we know that quality care is equitable care. There can be no quality without equity, and we must build equity into all of our offerings. At NCQA, we do this through our research, and hopefully you have been able to engage in many of our sessions and where we're developing new knowledge in collaboration with others. Through our measurement work, and I know I've gotten a couple of questions of people talking about measurement, but really using measurement to use our content to shine a light on health disparities and inequities. And of course, you've heard a lot about our programs providing solutions to enable health equity into business process and initiatives. Today, I get the incredible privilege of moderating the Health Equity Trailblazer panel titled, Where Vision Meets Commitment. I'm going to be joined here on stage by my fellow Justice League members, and if anyone that has heard me talk before, I look at this all in very much a Justice League approach. We all have our superpowers in this room, across the nation, to really help advance health equity. And I get to have a wonderful conversation with my fellow superheroes here. So I will call my panelists to the stage. We have Dr. Aletha Maybank, the Chief Health Equity Officer of the American Medical Association. We have Dr. Ronald Wyatt, Chief Medical Officer of the Society to Improve Diagnostic Medicine. Come on, give them a round of applause here. We have Dr. Asaf Batan, the Executive Director of Ariandi Labs. And then last but not least, we have Dr. Jonay Khaldoon, Chief Health Equity Officer of CVS Health. We can all sit down.
We're waiting for our call here.
That is.
You know, we're a team.
Hey,
All right.
let's get this talk on. So, part of the world of health equity involves this eagerness to learn. And I think as everyone has been here, you have realized that health equity is a growth mindset, and it's a journey. And actually, a couple of months ago, I was reading the book by Dr. Ella Washington called The Necessary Journey. And I think that speaks to a lot of the work that we have to do in health equity right now. It's the necessary journey. And one of the things I'm often talking to my health equity colleagues all the time is, you know, this is a long-term strategy. This is a marathon. And we always remember that one quote, the journey of 1,000 miles begins with one step. And I'm always encouraging people, just take a step forward. Don't be paralyzed. Just take a step forward. So Dr. Washington, in her book, The Necessary Journey, she talks about 5 different stages, which I think we're going to have a lot of our discussion around this idea of awareness, adherence, how do we tactically do health equity, but then how do we integrate health equity and not just making it its own thing, but making sure that it is embedded throughout all of our offerings. And then most importantly, the hard part, the sustainability. So just before starting off, you know, I know for me, every time people ask, like, why do you do what you do? You know, I always like to start with the why. So from the awareness perspective, I just want to ask each one of you, starting with Aletha, you're going to be my first one here, is what's your why when it comes to health equity?
Well, first, thanks for inviting me to be here. Awesome to be in community with my co-panelists who, for the first time meeting in person, it's amazing. We've been on Zoom calls together for, I feel like ever, even though they haven't been forever. But And then I'm really thankful for your leadership as well, Brian, and the work that you're doing. So my why, I think it's evolved over time. The more embedded that I become and the leader that I become in this space, I would say it goes back, the core of it and the simplicity of it is just the belief and the core belief that as human beings, we all deserve to be treated equally, equitably, right, and just as human beings that should love one another, a context that we don't talk about in healthcare much, the concept of love, and really do this because of that belief for myself, for my family, and for my community. Why wouldn't I and we want for everyone to have the same opportunities as everyone else. I don't understand that, and I see the simplicity of that the more I do this work, and I go to the simplicity of that, the more that I do this work of how much do you really care? And do you really, really care? This whole context of healthcare, what does that really mean? And I think in the quality and safety space, there's such a explicit and direct opportunity to address care in a way that other spaces in healthcare actually don't have as easily, and you can't see as easily. But the context of just caring for another human being is my why. Of course, I have lots of experiences that I'm not going to go into in terms of my life experience, but at this point, to me, it's just really simple.
Like that. Ron?
Yeah, so first, thank you, Brian. Thank all of you for being here. And as I go through this, I will say, think about what Dr. Maybank just said. And everything I will say is what she just reflected. So my why is back in the summer, one of them, back in the summer, my brother died. After a 2-year struggle with myeloma, he died. 2 years prior to that, he was admitted to a hospital in Northern Virginia in septic shock and kidney failure. And when I talked to the team taking care of him, well, when I first talked to the physician to find out, and this was during COVID, his wife couldn't visit him. When I talked to the physician, ICU hospitalist, who I've never met, he said, well, you know when these people come in. And I said, okay, now let's start over. Because I'm talking about my brother that I grew up with. So he started over, and when my brother left the hospital, a bit about him, he worked at a supervisory level in the Internal Revenue Service, 2 master's degrees, one in information technology, one in an MBA. And his team was responsible for disaster recovery for the Internal Revenue Service. He had, I would say, the Federal Blue Cross Platinum card. So when I talked to him, he said, the way I was treated here, I might as well be dead. He said that I was not respected, I was spoken to rudely, I was not shown any empathy, and he said I was treated like a checklist, but they didn't see me. They didn't see me. So he said, I might as well be dead. And then, which was a bit outside of his personality, he asked me, he said, do you think that the way I was treated had anything to do with the color of my skin? And he was just not the person that would bring that up typically. And I could go on with multiple stories like that, but all of it reflects what Dr. Maybank just said. He was not seen. He was not heard. And to your point, Dr. Maybank, he felt that no one cared about him other than checking the boxes for his care. So that is my why, among many others, that continues to motivate me to continue this work.
Thank you. It's so wonderful to be with you all. Wonderful to be with you all too. So it's hard to encompass a why in 92 seconds, but I'll try. I guess the first part of the why for me, I was an immigrant to this country as a kid, and one of the things about being an immigrant is that it gives you a different perspective on a country that you come from. You look at it as an outsider, and you can see the greatness of a country, and you can also see its faults and its challenges. And for me as a kid, what stood out, not like where I was coming from was a land of equity, but what stood out was inequality and inequity in so many forms, race, class, income. This is the wealthiest country in the world, and the incredible poverty that we have, sometimes sitting side by side. That stood out, and it always stood out, and it bugged me as a kid. And then when I decided to go into the health professions, for me, I was initially interested in public health, and public health gives you a lot of the why. It talks about populations, it talks about who is counted, who is not counted, who is undercounted, who is not seen as populations. But then I also became a doctor and a primary care doctor, and Dr. White, I was thinking, what is the big sort of function and rule of primary care? It's the capacity to see your patients and have them feel that they are seen in relationship. That's where the value of primary care comes out. And so working in community primary care, you see a lot of data. You see a lot of, I work in a community clinic in urban Boston, you see a lot of data that is stories, the qualitative data, the story of inequity lived and embodied literally on the bodies of people and their mistreatment and their journeys to care and to not care. And also you look at, and the focus of this conference, you look at data in numbers. And how can you not, in primary care and in all of healthcare, take the disparity and not be outraged and not act? And that's, I think, our opportunity here, is to see and help others be seen, walk with them, hear their stories, look at the data, do differently, sustain.
Yeah, really excited to be here. Excuse me, to be here with the team this morning. You know, just like the others on the panel, you know, my why is very, very personal. So I'm a descendant of slaves in the United States. I do not know before this country where my family is from. And so there's a couple of things that really stand out to me when I think about my why. One is my paternal grandmother. I just had the opportunity to celebrate her 97th birthday with her in Detroit. So just really excited about that. But she grew up poor in Mississippi. And she'll tell me these stories, and I've had a lot of time with her in the past several years. And she tells these stories of when her mother passed away. And she basically shares this story of her mother being 3 months postpartum after she had my grandmother's younger sibling, being 3 months postpartum, having a little difficulty breathing, not feeling well, and essentially my great-grandmother passed away with what was likely a maternal mortality. A few months after that, my paternal great-grandfather was found dead in the Mississippi River. He's African-American. Back in the day, people didn't really investigate that. So we don't know what happened, but we believe he was murdered for many reasons, and no one really cared and cared to investigate. So fast forward, I decided I wanted to be a doctor because I wanted to save the world. I ended up going into public health as well. But my intern year, I'm an ER doctor, my intern year of residency, I was pregnant with my first child, was very healthy, was exercising throughout my pregnancy, and then essentially had a botched epidural. Ended up having a C-section. I'll make this story short, I promise. But essentially, I was having really bad headaches after I delivered my son. And I remember being postpartum that night and going to my nurse and them not even looking up from the nurse's station, not answering my call button, looking at my chart and saying, "Oh, your first baby, you know, whatever, you're just complaining." I went home and I suffered for 3 weeks. Literally crawling on the floor with my head in my hands because it hurt so bad. And then finally, I decided, you know what, I've got to do something. So I called my co-resident, and again, I was an intern in emergency medicine, and I said, you know, something's going on. I need an internist or something. And he said, well, Jonae, what's going on? I'm like, well, I've been crying because like my head is just killing me. You know, they're like, what are you talking about, Jonae? That's crazy. Come on into our ER. And so essentially, I was diagnosed with bilateral subdural hematomas at 3 weeks postpartum. And really was just dismissed, and almost died. So I had my skull cut open on both sides about 17 years ago this month. And really for me, I shouldn't be here. I'm an ER doctor. I've seen CAT scans that look not even as bad as mine was, and I've pronounced those people dead. And so for me, my why is about I'm here for a reason. I had that experience for a reason. And absolutely, I believe that everyone should have a fair and just opportunity to be as healthy as possible, to be seen, right? And so that is why I do this work and why I've dedicated my career to public health and healthcare.
See, this is why I love my public health peep here, all talking about this too. And I appreciate everyone sharing their why and hearing some of the themes of being seen. It's personal as it comes to how you actually experience healthcare. And for those that heard me at the health equity breakfast the other day, you know, this actually kind of reminds me of my own why. For those that don't know, I had my first child in August, and that changes your perspective of the work that we do in quality, the work that we are doing around equity. It's about our children, your mother, your father, your siblings, your future kids that you might have. It's this whole idea of future people and how do we actually think about building systems for future people. And so I know that's something that resonates with me as I'm thinking about my why. And so often we hear about it from kind of going down this necessary journey about the awareness, and we hear these stories. But then we get to this point of adherence, and I think we kind of saw this during COVID where, many people are doing equity work because they're doing it just because they feel like they have to, not because they're seeing it as the moral imperative that needs to be done. And often I hear folks talk about, the return on investment for equity. And so Ron, I'm gonna kind of push this question to you, because often we hear about the return on investment, but I also like to think of the inverse of what's the cost of not doing this work?
Yeah, so I think if you just look at the data and the facts, that tells a story. And if you look at the data and facts about inequity and disparity, we can go back at least to 1619. We can actually go back to 1492 and come forward on a system that was designed to get the inequities that we see. So over 400 years of inequity that we all pay for. So what we see, and it's why I anchor in the moral imperative for this work as a starting point. There's not been a lack of investment in health and healthcare. If we just look at the cost of disparities for African Americans in the United States, it's approaching $451 billion. But the same, even more, applies to the white population. So the money is in the system. The question is, why is that money not allocated, I'm just going to say, in a morally correct way? Why are the resources going to where the resources are most wanted and not where they're most needed? What is the cost of devaluing a population? What is the cost of devaluing a community? What is the value of devaluing an entire people based on nothing more than the color of their skin, their ethnicity, how they worship or love? There's a cost to that. And we all suffer from the cost of that. That is the harm. That, for me, is a moral driver to say we have the money, right? And I'll go back to my brother. He had Blue Cross, right? So that system was going to get paid, but something else happens, and it's a moral failure that people are devalued in this healthcare system every single day. So how do we put a moral price on the devaluation of people and restricting resource allocation by design? It's not happenstance. It's designed into the system. And we scratch our heads, especially with COVID, saying, how could this be? We knew what the situation was before COVID. Right? So it should, and I say to people, if you're shocked by what happened with COVID, I'm shocked that you would be even shocked. Because the data was already there. You can map it out. You can put a cost on it. And when we talk about the green dollar cost, but what is the cost to a family and to a population if we continue to do, I will say, harm, and we will continue to not intervene where we can prevent death? And you can go across the country, and I'm headed today to another place where in a 5-mile radius, there's a 23-year difference in life expectancy. Where I lived on the west side of Chicago, if you go from the Loop up to where I lived on Western Avenue, there's 8 train stops and almost 20 years of life lost. And you can go across the country. What is the cost of seeing that and not saying we can do something about this? And we can do something about it. It's not a lack of resources. It's not a lack of money. It is a lack of commitment to correcting this problem.
I love that. And often in the work we have, especially as 3 years later after George Floyd's murder, you're starting to see things kind of slowly ink back where people are trying to get back into this resistance now around health equity, not seeing it to the point of the cost of not doing it. So Aletha, I'm going to ask you this question because you've been in this space as well. And I've always been struck by some of the things you've talked about with changing hearts and informing minds. How are you addressing the resistance and pushback for individuals and leaders and groups that want to really embrace equity?
Well, thanks for the question. I think it's important to contextualize resistance that's not new. at all. It's a phenomenon that's been here, and if you have those who are seeking their value in life through power and greed, there's always going to be resistance to anything that is disrupting that. And even by the folks who aren't even experiencing or have the opportunity or benefits of that power and greed because of the narratives and the lies that they've been told about their lives and others' lives, that they're better than others, right? And that there is this hierarchy of human value based on gender identity, based on race, with white being considered superior and supreme. So resistance to me is an expectation that we should, again, not be surprised about. We've seen it time and time again, post-slavery, what happened in Reconstruction. Oh, these are just, it's part of the story. And so I think when you come prepared with that knowledge, and you look back at history, and again, this is the historical part that is really important for us to know. We need to know our history. We need to learn our history, understand where we are right now physically. But the challenge is if we don't understand our historical context, we can't see that vision. We can't see the possibility because you get stuck in the current moment of like, oh my gosh, what do I do? How do I do this? This is happening. Like, no, there are actually many ancestors' shoulders that I stand on that have had to do this work, have had to lead with courage, have had to speak truth to power in moments when it's really difficult and challenging potentially, and actually life-threatening. And so that's the commitment that I think many of us in the health equity space come with as we go to lead this work, have been leading this work. You know, I look at, Ron, and the work that you've been leading for a while, right?
Yeah.
And I think, but it's important for us to acknowledge that. I'm very careful of how I say that, because sometimes that doesn't even come across right. But of that kind of present ancestral possibility and process that's happening. And so in leading this work within an institution like the American Medical Association, understanding the influence that it has outside of even the American Medical Association, I don't think I would have been, or let's put it this way, I'm as, in quotes, successful that I am because of the preparation that I've had before this in terms of being able to have a space, have a leader. I worked under Dr. Mary Bassett, who many are familiar with, I'm a very public health person as well, serving as deputy commissioner, and who gave me that space, within a space that I was a little bit more protected, to stand in my truth, to speak the truth when it mattered. And so as I transitioned to AMA, the context for me just didn't change, But also, I think as you lead with this work to bring people in, all of us come from a space of compassion. And if you come from a space of compassion, I've learned, and love, and it's not always easy to do that. It's easier for me to call people in, I found, to be able to create the space and hold accountability for folks to hear each other's stories and to listen. Because I don't believe we move our will and our hearts and our desires to love one another better if you don't know the stories of each other. If we're not in proximity with one another, we're hearing the experiences of one another in an emotional way. That's just human nature. We can do the technicalities of this work, the system change, the numbers, the data, all of it, but that's not the sustainable, leading, transformative pieces of what does it mean to build and create a healthcare system that cares, a society that cares about its people, beyond the greed of all the other systems that we do have. So, that is what I mean when I say this is heart work. I've done this enough years to know that giving numbers is not enough. There's a Meredith Minkler, who does a lot of work in community organizing and public health, says, institutions are moved by numbers and people are moved by stories. And so I've always, I think as my career has moved forward, I've seen that demonstrated over and over again. So the more that we are able to make injustice visible, make injustice visible, not invisible, visible to one another, for one another, the more helpful I feel it is not at the but not at the exploitation or extraction of those who are experiencing the injustice. That's a really tricky moment, but I still think the more we're able to shed light on the stories and the feelings and the emotions of injustice, Janae's story, you know, how can you not walk away from hearing that and be just a little bit moved and switched and triggered just a little bit? If not, then I don't know what kind of human being you are, honestly.
And we know stories have power when it comes to transforming organizations. But as we're even building this idea, I'm going to shift slightly to tactics. And I know Jonae and Asaf, you guys have been working a lot in this space of how we think about some of these tactics. So Jonae, I'm going to actually think of your shift from public health into more of the corporate CVS health work. You know, how are you trying to fit and embed equity into all of the offerings that organizations are doing at that top?
Yeah, thanks for the question. I want to build upon what Aletha said, actually, because when I think about, this work, I truly don't believe, and there are some exceptions, but for the most part, people are not walking around saying that they want inequities to exist, that they think that there's a subset of babies that should die before their first birthdays, or that they think that some people should, have a shorter life expectancy. So by and large, most folks in any organization actually want to do the right thing. So I think when you're doing this work and you meet quote unquote resistance, it's really about fear. It's about a fear of loss. It's about a fear of change, of uncertainty, of not having enough time, money, of losing something, sometimes losing privilege. And so when you come to the conversation with that lens, then you have to think about, okay, let me understand where this organization, where this person is coming from. And then you start listening. So what are the goals and objectives of the organization? How can you really think about embedding health equity very tactically, which I'll get to in a moment, into an organization's goals. And so at CVS, this is exactly what we've done. We've actually created a health equity business unit assessment tool that's built upon the IHI, the work that Aletha's done at the AMA, class standards, other kind of very, very clear NCQA health equity accreditation standards. So we've actually created a tool where we literally go business unit by business unit, walking those business units through, okay, I know you've got your annual goals and objectives. You've got metrics that you've got to meet. So this is the health equity lens on top of that. So how are you thinking about your data? How are you thinking about your teams and training of your teams? How are you thinking about engaging with communities? How are you thinking about really embedding health equity into your policies and procedures and access to the services that you provide? And so we've created this tool. We actually have a numerical gradient system that we score our business units on. It is internal, so you all will not be seeing it. It is internal. Everyone does not get an A, right? But what we do is as we walk these teams through this tool, they're able to assess themselves and then really track improvement. You have to have very specific goals, metrics, objectives, and they have to align with business goals. I would say for anyone who's in this space, I come from a public health space, in the health equity space, you have to really speak the language of the organization and the people that you're working with. Again, generally, people want to do the right thing. They often just don't know how, and they often don't know how to integrate it into their actual business goals and objectives.
I love that. I love the fact that you were trying to change the system, even going through that assessment. The process itself, is its own enlightening to be, okay, where do we see the gaps? And so shifting a little bit to you, Asaf, we know this work tactically involves a lot of organizational behavior and really that behavioral change. And Ariadne Labs has done a lot in this work. And one of the things I've always loved about is the no-do gaps piece of it as well. And how do you actually integrate this into the organization? So if you could share any light on how you guys are approaching it.
Sure. Yeah. Thank you so much. Really, been really appreciating being in conversation with you all and being in conversation with you all too. So, for us, the no-do gap, and no is with a K, is the gap that exists everywhere in healthcare if you want to look. And I think that gets to this why question. Why would you want to look? Well, because the no-do gap results from all of these things that happen across healthcare where we know what should happen. We have more evidence and more standards than actually most other fields. But you know that there's a difference between what we know and what does happen. And there's a difference in global outcome for everybody, and there's particular differences inequitable differences that happen for a lot of different populations. And the question to start with is, are you looking for your no-do gaps? Are you looking across your institution, and are you making equity? So here's the problem and the challenge. Are you making equity just another service line, something you do on Tuesdays, something you did for 19 months and then you were done? I mean, that's the real question. That's a leadership question. We can talk about the tactics, but that's a leadership and focus question. I just want to highlight something that Ron said. He said, the question is, many of you are sitting there with your coffee and you're wondering, well, Asaf, but we've got such financial pressures, and I hear that. But on a global leadership in your organization and healthcare has so much money in it. What are you using your money for? And then you're probably thinking, well, Asaf, maybe you haven't heard of the no margin, no mission. I've heard of it. Do you know that Sister Irene Krauss, who was the head of the Daughters of Charity Health System, do you know what the second part of her quote of no margin, no mission? No one ever talks about it. Mm-hmm. She said, no mission, no need for margin. What's the point in the margin if you haven't figured out your why? Your health system's why. I think most of your health systems, most of your work is in service to the communities that you are in service to. Add that we spend 19% of the entire most wealthy nation in the world money on healthcare. Add to that most of our health systems are nonprofits, which means they get huge tax breaks. So I ask you, what are you using your money for? Do you want to build the next glassy atrium in your hospital? Do you want to build the 4th PET scanner, the 5th MRI suite? Or do you want to invest meaningfully in equity? That's the choice that you at the top of the leadership cascade have to make. And then you go, if you've decided that you can take a meaningful focus that's not 18 months in the service line and someone else's job. That's the other thing that happens in healthcare, because it becomes someone else's job. Often people of color, often people who are here. They're going to do health equity, and the rest of us are, what are the rest of you doing? We're all in this together. We serve communities together. We find those gaps. We name those gaps. We name them because those gaps result in preventable suffering. Preventable suffering that's inequitably distributed. And then you build, and this is why organizations like NCQA and having a method for improvement and for not just getting the numbers, but then assessing the numbers, building the tactics, building the lens, not the service line approach to health equity across your organizations, and making this a commitment for the lifespan of your organization. Because show me a better commitment. What is otherwise the mission of the organization? So you bring the rigor that you bring to all the other service line works that you have, but you don't make it a service line. You make it a focusing sort of lens by which you see, and then you keep iterating. And you keep moving in partnership, and you keep building in partnership. You don't have to get it right the first time, because you're not going to get it right. There is no exact right except improvement and learning from improvement, and that commitment to sustained leadership and change.
I love that. I love that you mentioned that second part, because often we always hear the taglines, but we always don't read the full context. And this is why even as we've been talking, it's important to understand the context. If you don't have that mission, because I often ask people, if you are doing health equity, show me your mission statement. That should be what you're trying to achieve. And often, we shouldn't have to think about that return. It's part of your mission as a whole. So you also mentioned, and all of you have kind of alluded to this, and I've said it, and I mentioned at the start that this is a justice league, that this work, health equity, cannot be done in isolation. It's not just one person's job, it's everyone's job. I think of the patient safety movement, quality movement. It's not just one person. There might be an officer here, but it's everyone. Everyone should be building that muscle. And so as we think about partnerships, I'm going to go to you, Aletha, here. We know the power of partnerships, and even some of the work I know for NCQA working with the Rise to Health Coalition, I would love to kind of give an idea of how we're also looking at this at the macro level of health equity can't just be NCQA's thing. It has to be across the whole entire healthcare continuum, across all organizations.
Sure. So this is where I think you get the intersection of, community organizing principles. And, I go to that, and a lot of folks who are on my team have been organizers of some sort, whether within their institutions or whether within their community, whether political organizing. The whole context is power, right? How do you build power in order to create change? We use it all the time. It's part of our society and how we even believe in our democracy or the value of our democracy is building power for change to happen. And so a lot of the coalition work that we're doing now, so we have the Rise to Health Coalition, of which NCQA is a partner. Many other folks that are in this room have been partners. An opportunity not to really create, I'm very conscious, my team's very conscious, and thankfully to Dr. Karthik Sivashankar, who many of you are very familiar with, really a lot of his vision in doing this work and some of the work that we've done with other health systems across the country around embedding equity into quality and safety, is that there are a lot of folks doing a lot of things as it relates to equity. We didn't want to really reinvent that context, but more so provide an opportunity for all the folks who are doing work in health equity to have a space to come to one, share what they're doing, but also find those opportunities of where we can actually operate in solidarity together. So the context of solidarity, and this is where it kind of comes in as it relates to community organizing. I've been thinking a lot more about what does that really mean, because it's another word that kind of gets thrown out there, even in the equity space. And recently I have the fortunate opportunity to co-chair a Lancet commission right now with Brian Smedley, who was very involved in editing Unequal Treatment, the first one, Zinzi Bailey, a leading leadership who does data for Black lives. And we're doing a commission on decolonizing health and anti-racism and all that. Bringing together top-level, leaders, folks you all know in health equity space. And let me tell you, getting those folks, same vision. We all have the same vision of where, we want to go, and humanity loves human rights. But to get these folks to agree, beyond, because they all have different ideologies and understandings of how they approach the work of equity, and getting these folks to kind of come to agreement is going to be a lot of work. And so I also think about when we start to bring folks together, institutions, to build power in this way, what are we willing to let go of as individual entities, as institutions, as well as individuals, in order to move forward in solidarity. I think that is happening and playing out in our global world today, but it also operates within our institutions and amongst institutions. And the better we're able to figure out those points of connection, those points of alignment, I think the easier, and maybe the more comforting also, it will be to drive change, not only within our institutions, but again, amongst the context of each other. And sitting here, so I'm not in conversation with my colleagues. In different ways we are, but not in this kind of way to kind of actually just sit and listen. And two things happened as I was sitting and listening. So as Janae was mentioning the internal work of transforming an institution, and that's a very unique part of doing this work. Not many people actually have the ability, have the skill set, experience, the leadership to allow you to do that type of internal work. And that internal work is difficult and hard, but what I said to myself, I'm gonna, strategy, like I'm going to call Janae, right? And she's gonna present to my team, at the AMA, and I say that, and it's not that people aren't leading the work within the AMA and the management team, so I'm not trying to call my folks out in that way. But I'm going to be real, and folks who know me, I'm going to be real, that not everybody's on board with doing this internal aspect of looking at your own selves, looking at your own business units or your own departments in order to step forward and challenge how you're doing your work, to implement that equity lens. We will get what resistance looks like. What do you mean? I don't understand that. Why are we doing that? And you'll get that repeatedly. And I'm going to speak for a lot of the chief health equity officers that are doing this work. Like, it's hard. And so the opportunity to operate in solidarity with one another, whether at the individual level or the institutional level, I think is critical to this work at this point in time, especially because there are so many different pieces popping up all over the country. Lack of consistency and clarity. I think it's evolving more, and I think the work that you all are doing and some of the other regulatory spaces are doing is beginning to help us become more aligned in how we're doing it. But we need more spaces to learn and have a community of practice, per se, of what each other is doing, so that we actually not only have the power, but we feel supported and validated in the ways that we're operating and thinking.
Of that. And Often, as you were talking about really that solidarity, I started thinking about that next phase of the journey of integration and how do we really make sure that we are constantly integrating. And Asaf actually kind of mentioned this is a growth opportunity, it's a learning opportunity, and where it's very much QI, where we are doing our PDCAs of trying to figure it out, and we've never lived in an equitable society. And so we're all trying to do this work together, and we know that there's power in doing this together. So Ron, I'm going to go to you because you have talked a lot about equity both in the QI space and how we use data to actually help drive this, but then also on the aspect of integrating this into the next generation of leaders. And I often tell a lot of my students, the cost of life tuition is really high. So take the scholarships that we get from these PDCAs and how do we elevate these learnings and integrating it to the next generation and not repeat those same aspects of history. So Ron, anything you can share on what we're doing in that integration space?
Yeah, so I think that it's critical in equity work that quality improvement is a part of it. It's essential, and it's essential as a science. And a big part of that is once you do the process improvement, quality improvement work, then you implement. You act on what the data is saying to you. If you run PDSA cycles and they're telling you we're not improving or we're getting worse, at some point leadership's got to say, full stop, right? This is not working. Why is it not working, and how do we get better? And from the session yesterday, there is no equity without quality. There's no quality without equity. And it's all wrapped up in patient safety. And the data, if you apply process improvement principles, will show you that. And even in process improvement work, back to the point, fear is a big word, right? So how do you overcome the fear when you see the data that you need? And I'll quote Deming and say you replace it with that knowledge. That's what quality improvement will get you, the knowledge. And we're at a point, I would say, for, at least from my perspective, this is no longer a nice thing to do. It is a must-do thing. So you use those principles, you stratify your data, and when you show that data to leadership once again, you say, there is an indifference here that we need to address. And back to Janae's point, people want to do well, but in the face of data and our interventions, if it's not getting better, why does that indifference still exist? And it goes back to the word commitment. So if you line those out there, and there are three areas I put this into. First and foremost is leadership commitment. Are you willing to say, we will be an anti-racist, multicultural, transformative organization? That's leadership commitment. Are you willing to say, we are committing to zero inequity? And as a leader, I'm going to say it, and I will hold myself and others accountable in the system to show that that's where we're headed. The next is, are we creating a culture of safety? CMS is telling us, you must now create a culture of safety, commit to building a culture of equity with required metrics now, where you can go out and apply your quality improvement techniques. And then the last one becomes process improvement, so that you know you're getting better. And when you see indifference, then you have to root it out, understand the root causes, put in place change theories and say, we can no longer tolerate this level of indifference. We will get better. And if you put out there and say, and I've only seen 3 places, hopefully there's some in the audience, where leadership has said that the goal here is zero inequity. And that's not aspirational, because there's too much harm being done. And in 3 places, and kind of breaking news, I know there's some folks in the audience that will be where I'm going to be tomorrow. So just know that I'm going to say to your leadership, why don't you make the statement, we're committed to being an anti-racist organization. We're committed in this system to truly creating a culture of equity for the population that we serve. We're committed to being servant leaders. And if you apply process improvement, quality improvement methods and techniques over time, it's not going to happen overnight. Over time, it will demonstrate whether that commitment is true or not.
I love that. And so this is the part which I think gets the hard part, because you mentioned, how do we get to zero? And I remember in my early days in public health, or even in Michigan, we'd always say zero harm in Michigan is the goal, and we should always be hungry to get to that zero. But for the sustainability, we as healthcare can't just do this alone. And so as we think about how, as organizations, healthcare organizations, how do we, the sustainability we know we have to do in partnership with community. And so, Johnny, how do we as organizations also not just make our decisions at that ivory tower level, but really engaging and co-create with the community and reach beyond and have a sense of humility to make sure this work continues and get that ongoing feedback?
Yeah, spend a lot of time in public health and organizations thinking about this. I think the biggest challenge that we have, I'd say both in public health and health equity, you can't do one of those without the other, is competition. Many of you may not recognize that there is a lot of competition in public health. There's a lot of competition in health equity, where it's almost like people get up and they think that they're going to be the ones that are the saviors of whatever that community is. They have all the data, they have whatever it is. People are like looking for that press release, they're looking for that badge. They want to go to their grave saying that they were the savior who helped do A, B, C, D, and E. And so I think, to your point about humility, organizations, people even within organizations need to figure out what is their true why. What is their true purpose? Is it for them to win the health equity or public health game? Or is it really, truly to improve the health of the communities that you purport that you want to serve? And so when you come at it with that angle, then you start thinking, okay, we've got data. You always start with data, right? So we see disparities in a particular community. What are the resources or what are the strengths of one particular organization? What do you have? But also, what are the strengths of that community? And quite frankly, what that means, and I did this in my work, leading health departments, what it often means is you're not at the head of the table, nor should you be. The community should be at the head of the table. The community should be a part of not only identifying the quantitative data, but the qualitative understanding of what the challenges are in a community, but then also, again, understanding that data, but also developing those solutions. So I think the challenging part is when you work in an organization that has power, if nothing else because you have money and resources, how do you kind of come to the table, not always having to be at the head of it, but asking questions, right? Showing that humility, saying, okay, that sounds great. Maybe you need to provide a little technical assistance, perhaps, and provide some resources. But how do you really center the community and community voices in this work? And how do you put your ego aside? Again, it's not about you winning the health equity game. It's about we win when we see these disparities and these gaps close. And the people in organizations, the people in C-suites are not necessarily the ones that are going to need to lead that work in order for it to be successful.
This is why I love my Justice League analogy, because all of us, everyone's trying to be Superman to some degree, but even as we've seen for my comic book friends, we know that he can't do it alone. He needs all those other different superpowers, and you know that as part of the community. And so, Asaf, you've seen this and often when we talk about equity, we usually talk about it in a US-centric mindset, but we know equity is not just US-centric. This is a global initiative and a global imperative, and Ariadne Labs has been doing work not just in the US, but internationally. What are you seeing that's helping around sustainability and keeping this movement going?
Well, really briefly, the good news and the bad news is this is a global problem, so you're not alone. You want to see inequity, come with us, and we have the privilege of working with over 25 countries, and you sadly see inequity for many of the same root causes, just splayed out even more obscenely in terms of profoundly low resource environments. The question then comes, and I think it comes back to what is anything that we say here going to affect what you do 2 Tuesdays from now? I hope that it does, but I have the humility to say maybe you'll totally forget all of this. But perhaps it's the lesson that I draw from working with many colleagues abroad, across the globe, and also across the street from my clinic, which is that you start, as everyone said, with a commitment and a shared purpose that this is what you actually do, not some other thing that maybe you thought you did. You're in service to others. You start somewhere. You use the data, but then you quickly, and this is what we learned from global public health, the only stuff that ever works, especially in the lowest resources environments with the most inequity, is a community partnership model that starts with real community partnerships, which means I didn't just ask one person that happens to be a patient in my clinic who I think represents that community, but that you would find a way to really hear a multiplicity of voices, not just here, but also hear the beginnings of solutions. Because the patients that you serve, the communities that you work with will tell you the answers. They'll tell you the problems, but they'll start to tell you the answers. So you don't have to do it all yourself. That's the good news. You just have to be in a stance of openness to realize that this is your business. And this is the other thing, because I know 2 Tuesdays from now, somebody's going to say, well, it's never going to change. This all stuff's too political. Let's just go back to focusing on our margin. And what I hope you say is that cynicism is a luxury of the privileged, and that the communities that we serve across the street and across the globe, they count on us to not be cynical. They count on us to not just say it's always going to be the same thing. Not that we're saviors. None of us. This is a partnership model. But cynicism is an approach that if you don't see the glass as half full at some fundamental level, then at some point you're going to stop trying to fill the rest of the glass, right? And so you cannot be cynical. That doesn't mean not be real, but it means don't just descend into that safe space. Press a little, be open, approach this with love, with commitment, with a point of view, with a passion, with a start, with a way of improving, and a realization you don't have to have the answers. You don't have to have the perfect right language when you start. You don't have to have the first 3 things that work from the start. You just have to start and be committed and learn and have an open mind and an open heart about it.
Thank you for that. Cynicism being an aspect of privilege. And as you guys have all heard from my wonderful superstars and superheroes in this Justice League, it starts with the why and that awareness of the need to change. And I love how you said, you need to start seeing that the glass is half empty to some degree. And when it comes to that adherence, knowing that it's a thing that we need to do, there's an imperative, there's a moral commitment to why we're doing this, not just doing it for the sake of doing this. When it comes to that integration, I've heard you guys talk about those tactics, how you're both talking business to people, translating, and I like to always tell some of my staff, we need to be change agent chameleons in this work, being able to talk the different language that people need to hear, but then also knowing we have to integrate this with partnerships, knowing that this is not alone. This is not just a US thing. This is a global imperative that we have to have. And as we think about sustainability, we have to also think about the privilege and power that we have in mind moving forward. So I just want you all to give a round of applause to our speakers here. And we have an opportunity to take a couple, hopefully 1 or 2 questions. So if you can go to the mics, we can take about 1 to 2 questions before we have to move on to our wonderful next session. And I see someone right there.
Maria Stanfield, Detroit, Michigan. First and foremost, I would like to commend NCQA for bringing the Justice League together. When I saw this panel, I was like, I don't care. I changed my flight from yesterday's to make sure I was able to attend today. And I want to ask something that, as I sat in my seat, I was really nervous about asking it, but as Dr. Maybanks talked, it gave me a little confidence to ask it. And the tagline, "No quality without equity," has been just like playing as a reel in my head since the conference started and it was thrown out the first day. But as an African-American woman, you don't often see 2 African-American women on a stage like this, so that's different. But if you're trying to get your organization to be real, not to just add staff, a health equity officer, a VP to say you have it and it's a trending topic, or you've ticked off something in a strategic plan, or you're doing it because NCQA now not just has MBHO, but has the health equity accreditation. How do you get them to be real when you start actually asking for that real change? Whether it's in marriage to what Dr. Calhoun talked about with your existing goals and now a cascade strategic model. And they see you as an African-American woman like, okay, it's inequity in as much as, yes, you may have the degree and credentials, but you're a Black woman. So it comes, and this is real, So your vantage point comes with maybe we won't take the ideas as valid. We've already hired the correct people. Everything's in place. So from whatever, from this is the way you've always done it. But how do you react to that? And I'll take my seat.
I mean,
I'll let anyone, yeah.
thank you, my fellow Detroiter. How you doing? I would say, and we've already said this, but the work of health equity is really not about the work of the chief health equity officer. So what does that really mean? Just like quite frankly, any position in an organization, you've got to find allies. When you join a new company, what do? You try to understand what the company's goals and objectives are. You try to find out what folks are doing, try to understand the language of the company, the business. And then you go from there. I am not the one. I'm not the only one at CVS Health who's talking about health equity. We have many people. Quite frankly, I have a budget, and I am actually funding people within different business units to do the health equity work. It's not just about Jonay building her team of superheroes over here in a corner. We're embedding it into the business. We have different lines of business. I don't need to be in the room. You talk about health equity. You want me to kind of help you, kind of train and all of that. We're doing that. But you be in the room when I'm not there, and you talk about health equity. So I think that's really, really important. I would also say when you're in these roles, again, I'll say it one last time, you've got to understand the language of the organization. You have to understand what the business goals are. Everyone was not born to be a health equity champion per se. Everyone's not a public health person, but people generally are good. I do truly believe that as an optimist, right? And so understanding that people are coming from a good place and they want to do the right thing, it's on us, I think, in this space to really understand and not get angry, quite frankly, when people don't understand language around, social determinants of health and health equity. Maybe just talk about we've got different subpopulations. Some of those subpopulations have worse health than others, and it's actually not good, and it's also costing us money, right? That's what you talk about, because maybe some folks aren't into the word health equity because it's been so politicized. So that's just a little bit of my journey and how I would suggest approaching the work.
So I co-sign everything that was just said, and I'm gonna push just a little more. Again, in evolving and doing these roles, I want to be really clear that I do not feel these roles are normal roles. I don't feel they're healthy roles, honestly, to have within an institution. They are needed roles because of the realities that inequities exist, and there's a core part, we hear this upstream, downstream language right now in the space of healthcare. And I feel a lot of the work that we're doing at an institutional level is downstream. We are working in a system, an institution that wasn't set up for justice and equity for the majority of people actually within this country. And so I elevate that because the more I do this work, the more I think about, honestly, the harm that comes to the people who are leading this work within institutions. I'm able to speak up a little bit more because I've always kind of pushed that, but I know there are many folks who have to be silent about that. They can't push that envelope. They are not supported by their leaders in the ways that they need to be. They do not have teams to call upon. And so my call to action to the folks within this room is that when you have folks who are engaging and leading this work, it's a lonely place. Understand it's a very lonely place to be oftentimes. As I'm sorry, I'm not remembering your name, but even just the courage to stand up in this audience to say what you said, I know is not easy, as she already alluded to, as she was giving her opening remarks, because you go back with all these things kind of in your head. Did I say the right thing? Did I push too much? Am I going to lose my job? All these things happen when you start to speak up about equity. And what I ask is for those who are in this room who may not have those roles to reach out to those individuals who are leading this work within your institutions at whatever levels they are at, and just say, I'm here. I'm here. You don't have to know what to do or how to do it, but that I'm here as support, because over the last week, that has been one of the most helpful things for me to do and have actually in this job at AMA, is when somebody has reached out as an accomplice, not just as an ally, but an accomplice with me in this work within the institution. And that's what we really need. It's not about this community. We're a community ourselves as well. And I think it's that kind of distancing that also is not helpful. We have to see ourselves as part of this community of people and human beings who all desire to be loved and to be healthy.
Thank you for that. So once again, just a thank you to my amazing panel of superheroes. Thank you for all of you in the audience for all that you are doing, both actively and also kind of behind the radar to advance health equity. We appreciate it. We know it's not an easy road. Before concluding and making sure that we end our Health Innovation Summit strong today, just a couple of housekeeping before we exit the stage. We'll get ready for our next panel, which will be a conversation with Mina Shashamani and Michelle Schreiber with CMS on how all the things that we've been talking about, how do we actually think about this alignment at the federal level? And I also want to make a big plug because it's not in your app. So this is something, so take notes right now. We have a special add-on today, a special appearance at the end of the high note in the celebration of equity, which is the theme of this conference. The Orlando Gay Chorus will be presenting here on this stage in this room, so no we need to find anywhere, at 5:30. So if you're going to be here, please come back here to end the day off strong, knowing that we have a commitment to equity while we are here in Florida. So once again, thank you, and get ready for your next wonderful conversation.
Thank you.